Every prostate cancer goes through a phase where it is actually curable. By the age of 80, I'd say 70 to 80% of people have some prostate cancer cells. It will come to a point within, I would say, 10 years where the only human in the operating room will be the patient.
Mind your health.
You got to mind your health.
Mind your health.
Treat yourself. You got to mind your health.
Well, hello, welcome back. Today we're glad to have Dr. Buscarini with us, who is a noted urologist, and going to talk to us today about what's new in the urological world.
Right.
So welcome.
So very much welcome. I know you are from Italy, so let's hear a little bit about your background. I think that will be a wonderful way for us to start.
Oh, I started medicine at a very young age. We don't go to college in Italy, so we don't have those 4 years of freedom.
Okay.
Go straight from classical high school. And then as soon as I finished medical school, unfortunately, we had a draft back then. So I had to serve in the army. And I trained as a general surgeon in the army. I was deployed in various operating theater, in war theaters. So I was an army surgeon, basically, doing mostly trauma.
Oh, that's interesting. What a way to start.
Yeah, Yugoslavia, Beirut, Syria, Afghanistan.
Did you want to be a doc?
Yeah. All my life, I think.
And so after the service then?
After the service, while I was in the service, I transitioned into urology.
Okay.
And I was lucky enough that they accepted me. Mm-hmm. It was very difficult to get with staying in the army.
Sure.
But then I also developed interest in research, and I was corresponding with a very famous guy, scientist in Los Angeles. And at some point, I took a year of absence from the army and went to his lab to do a formal PhD. I had done a lot of research, so I was able to do it.
So MD, PhD.
Yes.
Oh, that's great.
So I was able to do it in a year and a half, less than 2 years, because of my background. But when I was in Los Angeles, I got interested in what was happening downstairs in the operating room. And there was probably the greatest open surgeon, who became my boss, because he gave me the possibility to spend a few years with them, retrained. So I did another residency, but I never regretted it because I was really an incredible group of people. And so I stayed there on faculty. I did an MBA mid-career. They paid for it, so it was actually...
So why not?
Yeah, why not?
You could have all the letters in the alphabet behind
like
your
it.
name. I love this.
I actually do, yeah.
I love that.
I do. I'm impressed myself.
No, that's my goal before I die. Every letter behind mine. Honestly, I love that for you.
Well, I don't know very much about the law,
Oh.
but pretty much everything else I've spent time studying.
I love this. How did you get involved in urology? And for the lay public, what really is urology?
So I got involved with urology because I thought it was the coolest surgical field. And urology deals with urinary and genital system.
Okay.
So you have people specializing in kidney, prostate, bladder disease, or, for example, something that's probably not very well known is we treat incontinence surgically and medically. And a big part of urology is also male sexual health.
Okay.
So we're like the counterpart of the gynecologist, and we do medical and surgical treatment for that.
Oh man, I got about 450,000 questions already.
You know, and I'm right there too, because where I thought you were going to go to is prostate, right? So I'm going to
you want prostate? I wanted to order incontinence.
well, I'm going to be 65 in 6 months.
Okay.
Did I read that prostate cancer is 100% if you live long enough?
Right. By the age of 80, I'd say 70 to 80% of people have some prostate cancer cells.
And why is that? Why does the prostate get
It's
cancer?
just a deranged mechanism of our aging.
Is it true across the world? And the Chinese and the Italians and the
Chinese don't really get a lot of prostate cancer. African American get very, very aggressive prostate cancers very early on. And Westerners, like Europeans and Americans, you know, there's still 60,000 people dying of prostate cancer a year. And but we do screen now. We screen after the age of 50 or 40 if you have a family history. We screen with a simple blood test, which is PSA, which is now, because we know that screening for prostate cancer saves lives. Every prostate cancer goes through a phase where it is actually curable.
Every prostate
Right,
cancer.
right. It's like colon cancer. They all start like polyps, and then they neglect them. So we're missing fewer and fewer cancers, and we're tailoring our approaches to the severity of the cancer. Sometimes when the cancer is just like having white hair, like we don't do much, or we just freeze or focal ablate with high frequency ultrasound. Sometimes these are new things. When the cancer is kind of aggressive enough to warrant surgical treatment, intervention, we use robotic surgery, and I've been doing it for over 20 years, so I'm kind of old now. And the latest development of robotic prostatic surgery is single port surgery, so we just make a small incision, and I'm bringing the technology here,
Wow,
which
it's
would
really,
be
it's minimally.
would be the only place between Charleston and Atlanta.
Wow.
So that single port surgery is just one incision and just this big, and it's an outpatient surgery. So it's a game changer.
So do you enjoy the oncologic portion of the urology?
What you would define a geo-oncologist.
Okay.
So a urologic oncologist. We have our society, we have our meetings, but here I do a fair amount of general urology.
So
like,
a broad spectrum.
well, like big stones, for
Yes.
example. Whatever my partners don't want to do, I get stuck with.
Is it fun to do different things every day? I mean, I think
Yeah,
that
I
would be
pay to do this
interesting.
job. Don't tell our CEO.
So I want to go back to the robot for just a minute. Explain what it is that the robot is doing. So the robot is not doing the surgery, right? You are doing the surgery.
Well, for now, you're
But-
right. For now,
But
I think
you're controlling
Yeah.
the instruments that are going in the body.
right. So
Now, if it's just one single port, obviously they're little things, little knives and little
right.
what?
Right, it's crazy. Yeah, I'm shocked like that I'm doing this. Like every day I can do this. I'm like I say, okay, I get to play with $2-3 million,
Machine, and it's a
machine.
blast. Yeah.
Yeah, it is. It is.
So what are you actually doing? Are you removing?
So the to go back to your point and to answer your question is that robotic surgery right now is still at in its infancy.
Got it.
Right now, it's a master-slave relationship. So you're the master, you are the surgeon, I'm the robot. I'm going to do exactly and I cannot take
Deviate from
independent initiative.
Okay.
What I'm working on with Cleveland Clinic is to develop a platform where you can have independent, automatic, with supervision. Robots will be able to do the surgeries
like it would
without
be
us.
Like an AI that would be collaborating
Yeah.
with the surgeon.
Right. So we're writing the codes. We have a lot of people working on it.
Is this specifically for prostate cancer?
No, it's for every robotic surgery.
Ah.
It will come to a point within, I would say, 10 years where the only human in the operating room will be the patient.
I mean, that's wonderful. gives you more time to develop a
Oh, no,
relationship with your patient.
Well, you still have to be there because, you know,
Sure.
we all know that AI hallucinates.
Right. I
you
hate
know.
it when they do that. Yeah.
Yeah, so we don't want AI to go rogue or crazy, but it will, like, the leading industry has already collected millions and millions of hours from the best surgeons, and you know, it will be possible to have this kind of accuracy, which is basically will render every surgeon a great surgeon, because
that's
you will
wonderful.
benefit
That's right.
from whatever. Let's say you've done 10,000 cases, you've done 25,000 cases, and I'm just starting. Maybe I can benefit from your experience through the robot.
It's so exciting. Medicine really is at a
Well, yeah, yeah.
crossroads. It's a lot. It's fascinating.
Well, AI will change everything, and I think we'll get rid of cancer within 10 years.
Wow.
With
Listen to your prediction.
All cancers?
Yeah, I think so.
Really?
With that's not my my theory. Is Dr. Mulcahy, the one Mulcahy, you pronounce it, the one the author of the Prince of All Maladies. You know, he won the Pulitzer Prize, and he's very much invested in the AI at NYU.
Are we seeing more and more cancers, urologic cancers than we did? Are we catching
We
them
are.
more? What is that about?
We
Is
are.
that-
We're living in a toxic society. Think
Okay.
about you know, all the toxins, like the microplastic, nanoplastics,
Right.
and the stuff that's that we're eating, or we're not here. Here's, you know, beautiful. I mean, you have great quality of air here, but I think we're exposed to we're breeding into carcinogens, and you know, my PhD is in molecular biology, so in biochemistry. So
Right.
you know how delicate a balance is. The thing is that what's happening in the States, and this is something that's worth understanding
Noting,
very
okay.
well, is that there is certain people who might be in this room, who are living longer and longer and longer, than healthier and healthier and healthier. And so the medicine, the advancement of medicine is affecting those people mostly. So here in my
To
practice,
improve their quality of life.
yeah, here in my
Yeah.
practice, I see people routinely in their 80s,
Okay.
and I treat them like if they were in their 60s.
Oh, but I mean, I'm 72 and I feel the same way. I don't feel any different really than I did at 40 or 50. And I feel like I'm actually healthier because I'm more informed and educated. And you and I talk about this, my lifestyle choices.
People exercise,
Yeah.
people take supplements,
Yeah.
people do screenings, sleep, doctors and the nurse practitioners, who are incredible help, are proactive.
Exactly. But that does bring us back to the question that I had when you went through what
But
what
it's
you
not
do.
across the board in
No.
our society.
No.
We're talking about this very specific
Finite group.
You fall into that. You go to inner cities,
No.
Yeah.
that's not happening.
I do want to go back, and I keep trying to do this. I do want to go back to incontinence because I do. What can I tell you? I think as we get older, I have 3 children who have had children.
Yeah.
So my daughters talk about it's sort of a ubiquitous thing that I see now with younger women, middle-aged women, older women. And I didn't realize men could be incontinent. Is that something that can be treated surgically with
Both.
exercise,
Both.
medicine?
So look, weight loss,
Okay,
critical. Exercise.
critical.
Understand that you own your muscles. You might not even know you have those muscles.
Okay,
So work with a good physical therapist.
makes sense.
Yes, and occasionally, involve a
Medicine.
doctor,
Okay,
some medicine, and rarely get a prolapse fixed
okay,
or a urethral hypermobility fixed. But I'm also introducing a new way of testing, which is a new old way of testing the functions of the bladder in men and women. So we're doing, we're starting. We already made the deal with the company, which they're going to bring us a miniaturized, newer version of what I call the EKG of the bladder.
Oh, interesting.
So we're
we
going
can
to
see-
know exactly what's happening with the pressures, and it's non-invasive.
Wow.
So it's minimal invasive, I would say.
There's a lot of really interesting
Oh,
things.
this is an old thing. I made my initial dissertation when back in Italy on this. But the machines and the technology has evolved dramatically. So it's in men, we don't even have to put anything inside to measure the pressures. We just measure with a little cuff.
And when we're talking about aging and we're talking about men and women's sexuality, that's something that you deal with too.
I deal with two, and in the rare occasions that it's needed, I also perform penile prosthesis, which is a huge, black hole in the men's sexuality. Like women are 20 years ahead
Interesting.
when it comes to plastic surgery
Okay,
or to reconstructive surgery.
got it.
We men, we have not been not been exposed to a gynecologist or somebody throughout our lives. So we are not ready sometimes. So right now we can fix 100% of erectile dysfunction, for example.
got
You
it.
just need to put the right equipment.
Okay.
And, it's like breast surgery,
Right.
breast augmentation. You see, some places in our country where, if you don't have a breast augmentation, you're some
Right,
kind of a
exactly.
rare bird. Now, I'm not suggesting that every man should
No.
get a penile implant or
Right.
penile enlargement, but if you have diabetes, if you had surgery, if you have bad vessels, and you have that problem, why are you not get it fixed?
Well, I think
There's hope.
I think the question is,
And most insurance companies paid for it,
and it's interesting because I think
and it's quality of life.
Yeah, routinely we women go to a gynecologist every year to kind of get checkups. Do guys do that?
We should go to the urologist after the age of 50.
Do you think men are more likely
No,
to?
they don't. They're not. They're
I
not
love
doing
it. I see. I get halfway through the question. I do that to you, don't I?
No, I wouldn't ever say that. So sorry. All right. So,
But you can give me. I'll give you my point of view. You guys give me your point of view, which is probably more interesting than mine
No,
as
it's-
a technician of the field.
Well, but I think we're giving lived experiences and things that we don't know the answer to that we're curious about, and we've got you grounded with a microphone on so we can ask the questions that maybe a lot of people want to know, and this is the opportunity.
so I wanted to get back with seeing the urologist in the PSA. So, so I went. I was going to my GP once a year.
Sure.
It's all good, and my PSA is going up and up. And I said, "Oh, like, what number should I be concerned about?" He said, "Well, it's not so much a number." He said, "It's the
trend.
rate of growth, right?" And so then I had a biopsy. Everything's good.
Good.
When should a normal, healthy guy should go to PSA every year at 40, 50?
So it depends, and there's international guidelines. We live by guidelines. They're a little constraining, but they help us. So if you have family history of an African American, 40 is the age when you start. Otherwise, the general population is 50, and then it's once a year.
And so as you get older, or my husband Mike gets older, do you continue doing that?
You stopped. Now this is a very interesting question because as people live longer here,
Yeah.
if you look around this population, again, I'm talking about this low country type of population and high socioeconomic status, high education, they're all correlated. I have my master's is also in public health. So these people tend to be healthier and live longer. There's no question about it. There's like tons of data, and the insurance company are very good at collecting those data. So now I am kind of moving my needle and still offer diagnosis and PSA on people in there. My cutoff, personal cutoff, and I've been talking to people around the country, is 82 years old. It used to be 75.
Oh, interesting.
Yes. It used to be 70 when I was first started. But, people are healthier and they take better care of themselves now.
So in my practice, what we're trying to get is a finger stick
Right.
PSA.
Yeah.
Because, like you said, so
A lot of pharmacies in Europe have it already.
So but it's not here in this country. And at 40 years old, I can screen a whole lot more people.
Yeah.
And what did you say the number was that, prostate cancer is curable? All of them are if caught early enough. Is that true? All 100%?
Yeah.
But the trick is finding those people early enough, right?
Yeah. It's
And is the PSA going to be the first one that jumps, or is it going to be urinary changes? Is it going to be?
So our field, it's evolved into precision medicine. You probably heard of that term many times, so I'm not saying anything unusual. So precision medicine incorporates a number of genetic and markers, tumor markers. Now, we all know the breast cancer tumor markers, the BRCA and this. As a urologic oncologist with a PhD background, I've always been very interested in incorporating tumor markers, especially urinary tumor markers, because I don't want to stick people in there
Right.
if I can't, and genetic testing. So this is the new frontier, which has to become, I think, standard practice. So I incorporate a lot of these, and they're commercially available. A lot of insurance companies have a hard time
Justifying that.
well, it's, as the prices come down, because, so it will be more and more. You don't really need to go to a genetics lab
Right.
and have now, of course, you have people like, as you probably, better than me, like Peter Attia,
Yeah.
who offer this, 3-day screening for an inordinate amount of money.
Right.
He's a smart guy and wrote a very nice book, Outlive, which I recommend to all my patients. But you don't really need to do that.
Got
If
it.
you have a good urologist, for example, a good GP, you can do most things now by yourself.
You said that, again, I keep going back to what you're saying too. So all prostate cancers are created equal at the beginning.
They're all created differently
Okay.
because
Well, because when I think in that time, what I think is with breast cancer, there are variations.
right.
Is prostate cancer like that, or is it?
So no prostate cancer is equal to the other because we're all unique.
Okay,
That's how we're made.
got it.
That's like there's nobody unless you have a twin.
Right.
But they share some, and we have our understanding is growing leaps and bounds with AI integration of diagnostics and interpretation of molecular medicine and the fusion of genetics with molecular markers. Now we know that most cancers share some markers and we can test for them.
Interesting.
And some of them require a little more aggressive treatment, while some of them you can just watch. That's happening with kidney cancers. For example, we used to operate everybody, and now we watch some of them. I've been watching, even here, I've had, my first 3 months, I've had some kidney masses that we can watch, and there is a lot of interest in that too. So
Yeah, tell me about that. So you would see the mass and you would not, tissue is the issue, take it out.
well, you can biopsy it, or you can assume that if somebody is old enough and the mass has been stable for a few years, that's a low-grade tumor.
Okay.
Now, I do a lot of biopsies for kidney cancers, but right now we're getting a lot of smaller tumors, and we diagnose them earlier and earlier.
What would be a symptom for a kidney cancer?
Well, the classic triad is flank pain, blood in the urine,
Okay.
and a palpable mass. Now, that happens only in 3% of the cases.
Yeah, okay.
But blood in urine, it's common. Blood in the urine is something that we tend to overlook, and it's never normal.
Okay.
So you always have to investigate it with, unless you have an infection, like
Right.
a young girl with an infection, young woman in the reproductive years with an infection, that's fine. But a man with, or an older woman, especially if he was a smoker, so get tested, okay? You need a CT scan and somebody to look in your bladder.
We've heard in the Low Country, I think, for years and years. You and I grew up with this probably. That kidney stones are more prevalent.
Right.
Is that true?
Well, I see a lot, so I suppose that there are. And I see a lot of big kidney stones which I treat through the flank with the small miniaturized incisions, so people go home the same day.
Oh, do they really?
Yeah, we just did 2 on Monday, and when they went home on Monday.
It's amazing.
Yeah, with laser.
I think it's you love what you do, don't you?
I paid to do it. Don't tell our CEO.
Do you like the business, public health piece, or actual patient interaction?
Or the hands-on.
Yeah, there you go.
Digging into somebody.
I forgot that piece.
I enjoy all aspects of it. I think I'm lucky that I got this sort of bike accident in this field, and the only part that I didn't like when I've been in academics all my life. I'm still on faculty at Mount Sinai. I haven't renounced that position. I just moved my clinical area here. The only part that I don't like is the politics that comes with big academic centers. And that's why now I collaborate more with Cleveland Clinic, who has a fantastic group of people, and really they're changing the shape of this #1 hospital in the world. So I like to be involved with them.
Oh, I
very
don't
much.
blame you. It's
Actually, I'm going there on Monday.
Oh, are you really? It's a fascinating field. I think urology is so sophisticated now, and there's so much.
It depends, most urologists in this country don't really continue to grow. They sort of keep on doing the same things. I've always looked at my field that if I'm still doing what I was doing 5 years ago, I'm doing something wrong.
We talk about that too. You and I talk about that, especially in pharmacy and psych. Oh no, my flip-flop.
And right now, it's going to be every 2 years.
Yeah, wow, that's fascinating. Well, we really appreciate you taking time out.
Oh,
of your
thank you.
day.
Thank you. You got me out of clinic, so
Oh, so that's a good thing, exactly.
very good thing.
And I think what we've learned is this was just a teaser, sort of the tip of the iceberg. The next time you come on, we can be very
Oh, is there going to be next time?
Oh, we'd love to have you in next time.
Maybe you like my accent.
There is
No,
that.
I want to have him bring his lunch or something. He said he's going to be a cooking.
Yeah, actually, that's what I was going to say. I think we need to.
I think we
test
should. I think we should
We
have
should
a
do a
kitchen
cooking
here.
class.
Yeah,
Exactly. But thank you so much. I want to
Yes.
thank all of you for joining us here on
Mind your health.
Mind your health.